Welcome back, everyone. My name is Robin Hilsebeck, and I'm an associate professor in the Department of Neurology at Dell Medical School and the director of the Comprehensive Memory Center at the Mulva Clinic for the Neurosciences. It's my pleasure to introduce our next speaker. Dr. Justin Rousseau is an assistant professor in the Department of Neurology and Department of Population Health at Dell Medical School. Dr. Rousseau received his undergraduate degree in systems engineering from the University of Virginia, his medical degree from the University of Oklahoma Health Sciences Center, and completed his neurology residency at the University of California, San Diego, where he was chief resident. Justin then completed an NIH-sponsored postdoctoral research fellowship and master's degree in biomedical informatics and clinical informatics at Harvard Medical School and Brigham and Women's Hospital. He holds the distinction of being one of the few, if not only, physician in the U.S. boards who is U.S. board certified in both neurology and clinical informatics. So without further ado, I will turn it over to Dr. Rousseau.
Thank you, Robin, and thank you to the Alzheimer's Association for inviting me to speak to this for this wonderful event. I'm going to talk to you today about a project that I've been working on locally, along with Dr. Hilsebeck, with the Comprehensive Memory Center at Dell Medical School, UT Health Austin, where we're building emergency alerts to support a data-driven delirium prevention platform for patients with mild cognitive impairment and dementia. And I have no conflicts of interest. This project is funded by the Texas Alzheimer's Research and Care Consortium. And so as some background, so delirium is an acute disorder of attention and cognition that people experience and can be triggered by subtle insults such as urinary tract infections or dehydration, and people with Alzheimer's disease or related dementias, as well as mild cognitive impairment, are particularly susceptible to developing delirium due to these mild insults. Things that we know about delirium is that it's a preventable condition, and we know that it can lead to an acceleration of pre-existing cognitive decline, and it also will lead to prolonged hospitalizations, increased need for post-acute care facilities. So patients who develop delirium who came to the hospital from home may not even be able to make it back to home, but may need to then go to an assisted living facility or a skilled nursing facility, and definitely leads to excess healthcare costs as delirium can present as with severe symptoms, leading healthcare teams and acute care teams to think that maybe something very significant like a stroke is going on. And so to give you some context, I want to take you through a case, a fictional case. So as a 70-year-old woman who lives at home with her husband, she's been having difficulties with her memory recently. She'll occasionally get lost in familiar places or misplacing items at home. She's responsible for her family's finances, so still able to take care of activities of daily living, such as paying bills on time, cooking meals for her and her husband. She did see a neurologist for her memory complaints and was diagnosed with mild cognitive impairment. And so one day her husband found her at home, confused, not knowing what year it was or where she was, and that was very concerning to her husband. She was barely able to concentrate enough to hold a conversation. He thought she might be having a stroke, and so he called 911. She was brought to the emergency department by Emergency Medical Services, and there they also suspected a stroke and did an extensive workup, and ended up finding that she did not have a stroke, but had a urinary tract infection that contributed to her developing delirium. And they were not aware of her history of this mild cognitive impairment that was diagnosed at an outside clinic. She was treated for her urinary tract infection and for some dehydration, which afterwards her cognition improved dramatically, but she wasn't ever able to get back to her baseline and get back to that point of being able to manage her household finances or meals. And so she and her husband have then had to look at moving into an assisted living center because they're not able to manage all of their daily needs. And so she's now progressed from mild cognitive impairment then to dementia. And so I mentioned before, we have seen in multiple studies now that episodes of delirium are not just benign episodes that then after you recover from whatever insult led to the delirium, you get back to your normal baseline. But in fact, we see that there's acceleration then in cognitive decline that might have been present due to a dementia or mild cognitive impairment. And so this study looked at hospital admissions in general, but among those was delirium that led to these acute drops in function, but not being able to make it back to one's baseline. And so delirium is also under-recognized and under-treated. I'm a hospital-based acute care neurologist, so general neurologist. I care for and am involved in taking care of patients who are already well into a delirium, and then managing that delirium in order to then get them as close to baseline as possible, and identifying what the underlying condition is that needs to be treated. In that setting, I see that there are many delays then in prevention of delirium, and there are well-defined delirium prevention protocols, but you have to be able to recognize someone that's at risk or someone that is going to develop delirium in order to implement those. And so we have a problem then with early recognition, as well as identifying patients who are at risk early in their hospital stay. And then also we've identified then communication gaps that could have led to early recognition and early identification. So in our case, we know that this woman was seen by a neurologist in the outpatient setting, and so there was information there that she had she was diagnosed with mild cognitive impairment, and so was at increased risk of developing delirium. And so for this project, we sought to then step upstream in an episode of care in order to potentially intervene earlier. And so one of those steps then is stepping out of the hospital and working with EMS, the emergency medical services, to potentially identify patients that are at high risk of developing delirium earlier on. So in the case that I described, the woman had already developed delirium when EMS had arrived, but there are cases where someone who's at high risk of developing delirium has an injury per se. So maybe she fell and injured her arm and needed to go to the hospital, but she's cognitively at her baseline, and if the hospital were to know that she had a diagnosis of mild cognitive impairment, then they could have implemented a delirium prevention protocol at arrival, or possibly even prior to arrival, and avoid like sedating medications that might then trigger a delirium. And so that so we have these three entities then that have various degrees of information on our patient: the outpatient neurologist, the EMS services, and the hospital, that they would like to bring together via a technical platform. There's a platform of alerts and sharing of information in order to then test test interventions that might be able to prevent delirium from occurring. And so for this project, we had collaborators of, so at Dell Medical School, the Comprehensive Memory Center, at UT Health Austin, which is our interdisciplinary care clinic, caring for people with mild cognitive impairment and dementia. And then we also collaborated with Austin EMS, which is the sole first responders to 911 calls in the Austin area. So we have a unique situation that in Austin, if we're looking at other areas nationwide that may have multiple EMS services, we have a unique situation where collaborating with this one provider allows us to then know about any and all emergency situations that are happening in the area. And we also collaborated with our regional health information exchange called Integrated Care Collaboration, or ICC, which already has an existing relationship with Austin EMS, where Austin EMS on a nightly basis will upload all of their encounter information to ICC. And ICC also has integrations then and interfaces with other local healthcare organizations, including the major hospital systems in the area. And so with this project, we sought to then design and implement an emergency alerting system for this population of patients that we know to be at high risk of developing delirium. And since this is a technical study, so we're testing the technical platform that then would be used for testing clinical interventions. We're then planning on comparing the performance of alerts that are coming directly from Austin EMS compared to those that are coming from the Regional Health Information Exchange. And so we're actually setting it up to where we receive both alerts from both sources and comparing the performance across the two. And so we are currently enrolling for this study. We have 30 participants enrolled already. Our inclusion criteria are broad. Any person who has a diagnosis of mild cognitive impairment or dementia, that could be Alzheimer's dementia, Alzheimer's related dementia, or other related dementias, and they could be seen in our comprehensive memory center, or they could also come from the community. And so we have been reaching out with our Department of Population Health as support resources to reach out to groups that might be underrepresented, as well as we have all consents, both in English and Spanish, to be able to include those that are Spanish speaking in our community. And once participants have consented, we then provide their information to both the Health Information Exchange as well as to Austin EMS, so that they can then integrate them into their information into their databases, and we rely then on the Health Information Exchange as well as Austin EMS to perform their own matching algorithms to identify when a patient matches the information that we have shared with them of those that have enrolled in the study. I mentioned before that Austin EMS and ICC have an already existing relationship of sharing data, and ICC also has an existing relationship with local hospitals for sharing of data. And so that's one of the reasons why we sought to evaluate the performance of the Regional Health Information Exchange, is to, if this is something that is feasible, then might it be able to scale to then identify if a patient is seen at some other hospital that or emergency department that contributes data to the Health Information Exchange. And so we have two separate alerts. We've got one alert that's coming directly from Austin EMS, and it comes from their electronic patient care record, which they refer to as EPCR. And the alert comes via email at this point in time. and they determine if there is a match with information that we have provided them about our participants based off of data that are entered into that ePCR in the field by field medics. And then ICC, the Health Information Exchange, they identify if there's a match whenever they receive the full encounter information from Austin EMS in their nightly uploads. And if they identify a match, then they also will send an alert via email at this point in time. There are capabilities of sending higher level HL7 via messages that could be ingested by EHRs at other clinics or hospitals, but at this point in time, we're only doing via email. And something to note is that both of these alerting mechanisms are activated by data that's entered via routine patient care. So we're not asking the EMS medics to do anything additional in their workflows. And so currently we're early in this process, but we do have bidirectional data use agreements between both Dell Medical School and ICC, as well as Dell Medical School and Austin EMS, so that we can then share information about patients or participants that we enroll, as well as receive information through the alerts. And Austin EMS alerts have been operational since August 12th of last year, and ICC alerts have been operational since more recently, March 4th of this year. And as I mentioned, we've enrolled 30 participants, and we are continuing to enroll both from our clinic as well as from the community. And so far, we have received one emergency alert notification prior to ICC coming on board. So it was via Austin EMS. And so what we've at least demonstrated so far is that automated alerts are feasible then using patient matching algorithms, both by the Regional Health Information Exchange and by EMS. And this alerting or communication platform can be used then for early identification and prevention of patients at risk of delirium. We need more data in order to evaluate the performance and compare the performance across the two sources. But thinking about future steps, a communication platform like this could be used in multiple conditions and populations of patients to support early identification, preventive measures, communication, and interventions. And so I want to thank then all that were involved and continue to be involved in this ongoing project at Dell Medical School, Department of Population Health, as well as Department of Neurology, the Comprehensive Memory Center at UT Health Austin, and Austin EMS, as well as ICC. And thank you as well to TARC for the funding support for this project. At this time, I'll take some questions.
Great. Thank you so much, Justin. And we do have some questions, and maybe we'll start with this very first one. How are you recruiting for the study?
So multiple ways that we're recruiting. So first of all, with the help of Dr. Hilsebeck in the Comprehensive Memory Center, we are then identifying patients who are eligible, who meet the criteria, and if they do, then the clinicians ask if they're interested in participating in any of the research projects that we have going on, and if so, then we introduce this project as one of them. And so that's one mechanism of recruiting. But then we've also, like I mentioned, we've been working with our Department of Population Health, as well as our Aging Research Center at UT Austin, where we've then got in contact with multiple community organizations that work with multiple groups that have dementias or are aging, and so then we've met with those and provided information about the project, so that then they can spread to spread information to individuals that they work with. We've also reached out on social media in collaboration with Dell Med School and UT Health Austin to promote the study. Those are largely it at this point in time.
Thank you. I know we're running a little bit early, but I'm not sure if we're trying to stay on our new time schedule or not. We do have more questions, so let's just take one more. Some great questions. This is a two-part question. Do you see any barriers in the implementation of disclosure of diagnosis, and what are ways we could help break those barriers?
I assume it would be barriers of disclosure of diagnosis from one clinical organization to the other, or and really because of HIPAA is there in order to share information about clinical information. If you have someone that is in an emergency situation where you need to know their clinical history. And so we really haven't run into barriers of sharing those diagnoses across clinical organizations. Part of that also we handle at the front end. So discussing with potential participants, we say that we will be sharing information about you and about your healthcare then with the Health Information Exchange and with potential sites or clinical organizations where you may be seen in the future. And so we haven't really run into issues of people being reluctant to share that. Whenever they understand that it's for best clinical care.
Great, and just one more question, then we'll wrap up. What percentage of people diagnosed with MCI develop delirium? If you know.
That I don't know those numbers off the top of my head. I guess that would be it. From a, I guess, anecdotal perspective, from my clinical experience, most often, I mean, there are many different types of delirium, but there's definitely increased risk. So in people who have mild cognitive impairment, and so even if that's identified then prior to a procedure, then that's something that you would that is recommended to start on a delirium prevention protocol. And I saw that was a question in there as well. And there's a New England Journal article from Dr. Inoue that spells out the specifics of delirium prevention, and it's largely non-pharmacological intervention. So things like frequent reorientation, opening up the blinds during the day, increase interaction during the day, and minimizing interruptions at night to allow for good sleep-wake cycle, and avoiding medications that are known to cause delirium.
Great, thank you so much, Dr. Rousseau. We really appreciate your time, and the study is definitely exciting. To prevent delirium would be amazing. So now I'll introduce our next speaker, Dr. Bo Shea. Dr. Shea is a professor in the School of Nursing and School of Information at UT Austin. She received her bachelor's degree in medicine from West China University of Medical Sciences in Chengdu, her master's degree in psychology from Peking University in Beijing, and her doctorate degree in science and technology studies from Rensselaer I'm sure I'm butchering that name, Polytechnic Institute in Troy, New York. My apologies for that. Consistent with her highly interdisciplinary training, her research has been situated at the intersection of aging, health, and information technology, examining older adults' learning and use of new technology and the design of senior-friendly technology. Dr. Chia's research has been funded by the National Institutes of Health, the National Science Foundation, and Institute of Museum and Library Services. Her research to date has generated over 90 publications on these topics. She is a fellow of the Gerontological Society of America, and we are very pleased to have her speak to us today. Thank you. Go ahead, Dr. Chia.
Thank you so much, Robin. Thank you for giving me this opportunity to participate in this great event. I have learned a great deal. Sorry. I have 4 children in the house with me. I thought they were under control, but I guess not.
That's life in the pandemic, no worries.
All right. So, well, thank you all so much for giving me this opportunity here. Thank you for your patience with me. My name is Bo Shi. I am a professor in the School of Nursing and School of Information. My talk today is entitled Developing Technology-Based Interventions for Dementia Caregivers. So let me go to my next slide. I use these 3 circles to basically show the large areas of my research, which basically has been focusing on the intersection among older adults, health, and information technology. Now, this is a very broad, of course, it's intentionally broad, so I could explore in whichever direction it might be most interesting. I have been focusing on older adults who are caregivers of persons with Alzheimer's disease and dementia, because as we have learned from our keynote speaker, Dr. Carrillo's presentation, 1 in 3 of the caregivers for dementia patients are older adults. So that's a very important aspect. My angle coming in is really in terms of providing information through technology. And this is because, well, as we all know, family caregivers of dementia patients also often feel that they don't have sufficient information about how to care for their family members and also what their care options are, the challenges they may face, and what resources might be available to them. It is also no secret that really information is power, and that these days technology has become a very important way for people to access information and resources. So there are many different ways technology can be used to improve dementia care, and I will use just as 2 examples. 2 of the recent projects that my collaborators and I have been developing that both aim to use, well, one aims to use artificial intelligence and the other one focuses on machine learning tools to hopefully provide dementia caregivers with much needed information. So one of the projects we have been working on is to use intelligent voice assistants to provide tailored just-in-time and multimedia information. So, for example, we try to use Amazon Alexa to provide that voice assistance to caregivers who may be very busy, where they may not be able to have the time to sit down and look at a pile of paper to sift through to find the most relevant information, but instead perhaps we could have picture a scenario where a caregiver is in the middle of something, then they could say, well, Alexa, tell me when mom's next appointment is, or Alexa, should I cook this meal to include X and Y, Z as a meal for a parent that they are taking care of. So we want to provide that tailored just-in-time information that is really multimedia, not just text-based that does not really require someone to have to sit down and read through. It could be multimedia. So that would be really exciting. And then in the other project we are working on, we try to use machine learning tools to better understand the caregivers' information preferences, based on the vast number of social media posts that they share on social media. The idea is that oftentimes we want to provide information that is what the caregivers want to know and the time that they want to know in the format that they like. So, but in order to understand caregivers' preferences, traditionally, as well, many of us have done, we would want to interview or survey or use or these more traditional methods to try to understand caregivers' preferences. And that these methods do have their advantages, obviously, in many ways, but also some limitations, obvious as well, in the sense that we will not be able to scale up in better understanding caregivers' preferences on a larger scale. Meanwhile, there is a large amount of data available via social media these days, where caregivers are increasingly using social media platforms, Twitter, Reddit, Facebook, or these social media platforms where they share their concerns and try to find information from their peers who may be in similar situations. So we were thinking, well, there is already this vast amount of data available on social media. How could we sift through and try to understand better what caregivers really want by using machine learning methods that can really work on a large scale, machine learning methods could easily analyze millions of social media posts, which would not be possible if we were to do this manually with our human experts. So this is this other project we are currently working on. The hope is that, well, after we have a better understanding of what caregivers really want to have, then we may be able to provide better interventions to give them just what they want, just in time and multimedia as well. So in our collaborations, both of these projects, we are really truly interdisciplinary. We have on board our wonderful clinicians, Robin Helsbeck and Alisa Greer, great people to work with because you bring with you great clinical expertise. We also have computer scientists who are trained in computer science, artificial intelligence, or machine learning. They really bring in the technology aspect. And I serve as the social and behavioral science representative on our research team to try to focus on our end users, meaning our patients or their family caregivers, what their preferences are that can really align well with what clinicians think patients might need to have or what computer scientists think users might need to do in order to get the information they want. So our collaborations, I have found the collaboration really been intellectually stimulating and really fascinating. I have really enjoyed this process. And I will also provide some more examples as I get deeper into the process. But let me just also, so interdisciplinary collaboration really is key, I think, to our development of technology-based interventions to provide the caregivers with the information they want. But here I put in small font. It's like, it's supposed to be a joke. Like oftentimes when we look at products, right? We look at the big flashy letters, say, oh, this is great. And then in really tiny, small font, there's some really cautionary messages that we don't really want everyone to know, but everyone should know. So as we engage in interdisciplinary collaborations, I want to caution everyone to really be patient. Well, if you have already done this, you know exactly what I'm talking about. And we need to be prepared for the initial cultural shock, because our disciplines are so different, the norms and expectations are so different. So typically, I would say the first 6 to 12 months, we probably would be spending our time just trying to understand what each other is saying, because sometimes we could be using the same term, but referring to different things, or we could be using, the other way around as well. And I'll get into more depth with one of the projects we have been working on. So this is a project that we have been working on, focusing on using artificial intelligence to understand how this new technology could be useful to caregivers. I will provide a quick summary of what we found in developing this this collaboration, this is systematic literature review, which I hope to serve two purposes. One is to show where we are in terms of the science, by which stage we are currently at, by using AI, artificial intelligence-based interventions for caregivers. And the other purpose is to show some of the challenges, the cultural shock that I was referring to. What we learned in this project was using AI to assist mostly in activities of daily living and targeting on a very limited number of specific activities. We found that there were a couple of teams who's been spending 10 plus years focusing on one particular task, like how you could use artificial intelligence to assist patients to wash their hands on their own. So this is a project, I'm not kidding you, people spend more than 10 years of their research on understand how to do this. So a very limited number of specific activities of daily living have been studied. Very exploratory, qualitative, small sample, theoretical. Small sample as in the sample size could be as small as 6, as large as 106. That was the largest we found. In terms of the methods, I mean, associated with the research being exploratory, it's mostly interviews, observations, and in some cases surveys, but really cross-sectional studies tend to also use small samples as well. In some cases, we found a lot of, in some databases, we found the research lacking empirical data from human subjects. Those were mostly technical specifics or system architecture for designing the AI systems. This is really a critical piece of information I learned in the process. We were using Prisma to extract preferred reporting items for systematic reviews and meta-analysis, which is a very, commonly used set of guidelines in health sciences. When we tried to extract the information from the relevant publications we found that many of the publications were actually missing key pieces of information, like they don't even report the demographics of their research participants, not even the very basic ones like age or gender. And in some cases, we found studies that did not even report the sample size, which was just, it was one of those shocks that I think I'm not sure about the academic background of the participants today, but my guess is probably mostly coming from the health sciences disciplines. So I think you can relate it to how I felt when I realized a lot of the publications, they don't actually even report demographics or even sample size, or not to mention the research settings or sites. In some cases, we couldn't even figure out, we had to try to figure out from the authors' affiliations to try to figure out in which country the study was conducted. So, but I mean, my collaborators in computer science, they were like, yeah, but that's how we do business here. What's wrong? So it was really fun, really interesting to try to learn that piece of the interdisciplinary collaboration. And then existing studies found mixed results. Some studies did find positive perceptions and reactions to the new technology they were developing, but other studies also had negative findings or mixed. One particular study I think found was also very interesting, where they found that caregivers had more positive reactions to the AI technology they were developing compared with patients. So it's an interesting trade-off, how we might be able to overcome potential discrepancies between different preferences between caregivers and patients. It's a big issue. We also realized that there was a little overlap between the health sciences and computer science and engineering databases. So we did anticipate there might be a little overlap. So we, in our literature search, we included the databases commonly used in the health sciences, and also we included the databases commonly used in the computer science and engineering fields, hoping to try to capture both. And that was a very useful strategy. So our main, we came to realize that research is still in a stage of technology development when it comes to artificial intelligence, and far from ripe for clinical evaluation, but which I think is actually a good thing, because it just means we have more opportunities for interdisciplinary collaboration. So this is one project I'm focusing on. And in this other project where we have been using machine learning tools to try to understand the caregivers' information preferences as they expressed on social media, we had similar findings where there's very little existing research on the topic, which is not a surprise, and the qualitative small sample are theoretical, and the reporting norms are different. So these actually, so I could say based on these two studies, one focusing on artificial intelligence, the other one focusing on machine learning, we see some common themes running across. But in this other project, this machine learning project, we actually went a step further in terms of developing, we are trying to develop guidelines that might work for people in the future who might want to study the intersection between machine learning or technology in general and dementia caregiving. Because what we found in our on the slide here, this is focusing on artificial intelligence. We realized that Prisma guidelines really did not work so well. So in this next project, when we use machine learning as this other example, we actually try to develop, I guess, machine learning, we are trying to adapt the Prisma guidelines to study machine learning, which means well, some of the elements will have to be removed, because and then other elements would have to be added, like what machine learning models were used in these existing studies, and or these different strategies, data source, what type of data people were using. Was it from Twitter? Was it from Facebook? So there are different interesting adaptations, but I will not get too much into this other project, this machine learning one, because we currently have this manuscript under review. So I hope we'll have some positive outcome from the journal review, and then I'll be able to report more on that. And that's a quick run through, and I will be very happy to answer any questions. Thank you.
Thank you, Dr. Shi. Very, very interesting to think about how to combine these two worlds and talk to each other to do this integrative research. I did not see any questions in the chat or the Q&A. Let me see. Nope. Does anyone have? Oh, here's one. So the comment is very forward thinking. It would be very informative to get more day-to-day data to see the pattern or progression for diagnostic purposes. Would it be able to also learn from tracking dementia-related behaviors to inform diagnosis?
Yeah, that was one of the things we did attain early on in our project, and then we realized it would be so ambitious based on our current the state of the current technology development, because it would really require a lot more data than we currently are able to retrieve from social media. Because typically we see on social media platforms, one person, one caregiver could be posting a message like 6 months apart, but it could be just the only 2 posts they make. But if we could somehow maybe think about a way where we could intentionally recruit or even build our own community, online social media community, we encourage people to try to contribute posts more regularly, maybe every week and for 3 years, then I think we would be able to have the sufficient data in order for machine learning tools to work, to hopefully identify any patterns. So it's promising, but and I'm very interested. I would really, anyone interested, please do talk with me. I think maybe I'll be happy to explore further collaborations down the road. Thank you.
Great. We have another question that came in. Can you talk some about what you see as the most promising technologies for caregiving in dementia?
Thank you. Yeah, that's another great question. I think technology really can help in many ways. Right now in the literature, as we have seen, many researchers have focused on using sensors to detect the status of the patient, like if a patient wanders around and if they got lost, or if they wake up too often in the middle of the night, how that change in their status can be captured and could be sent to clinicians or caregivers and then could be used for decision making. And that is a big, one of the major topics in the research that I am currently not getting into. So, but we actually, in our literature search, we did find a lot of the pointers. So if you are interested in that direction, please talk with me as well. I'll send some references. But in my own research, in our collaboration, our focus really has been on how we could use technology to provide information just in time, tailored multimedia information to caregivers that would help them better manage the patient on a daily basis and also help them make better decisions with regard to daily care or perhaps care transition from their homes to maybe a facility or end of life decision making. Our focus, because my angle moving into this this population is really from the information perspective. We really want to understand what caregivers want to know, which oftentimes may or may not align with what we think patients or caregivers might need to know, right? Because oftentimes what professionals think patients need to know may just not align. So we really want to understand, taking this bottom-up approach to really understand what patients and caregivers really want to know. Now, I didn't quite have time to talk about this. Another project where we try to understand the differences between patients and caregivers' values, human values and preferences, and how we might be able to reconcile if it's possible. It's very difficult, but that's another project I didn't get to talk about.
Well, there's one last question that I think is nicely, it transitions from what you were just talking about. So a comment from Annette Juba. I think it's interesting that you analyzed caregiver social media posts to determine their needs. I wonder if you noticed any discrepancies between what caregivers state directly that they need and what their posts illustrated that they need.
Definitely, there are differences, very clear, because we don't know what we don't know, right? So in the post we have analyzed, initially we were thinking we would want to study what information people are asking. It's like when there are people who go up on social media and say, "Oh my God, my father-in-law just did XYZ. Could someone tell me what I should do right now?" So that's one type of information wants. It's what information people want to have. But very quickly, as we get into the social media posts, very quickly we realize that oftentimes people don't specifically ask what information they want. Instead, they think they were just there to vent. So often, about half of our posts, they people who type up a whole page of really, you could see the strong emotions really floating there. And then in the end, they say, "Oh, I don't know what I'm going to do. I don't know. I guess I'm just here to vent." And then when we, as researchers, as clinicians, when we see this kind of messages, we have a sense of, well, maybe information or advice about XYZ might be useful to them. But they were not specifically asking for that information or resources. Maybe because they were not aware the existence of these resources, or maybe because they did not realize what they wanted. So I think definitely as researchers, it's fascinating to see what people say they want versus what they illustrate, what they show in their emotions that we think they might want or need. I hope I answered your question. Yeah.
Thank you so much, Dr. Shi. I think we will, we're at our time perfectly. Our next speaker, Dr. Heather Schneider, will talk at 12:30. So please come back.
The summer solstice. On June 20th, help us stand up to the darkness of Alzheimer's by raising funds for the care, support, and research efforts of the Alzheimer's Association. It's easy. Pick any activity you enjoy and turn it into a fundraiser to fight Alzheimer's. From bowling to basketball and card games to crafts, any activity can be part of the longest day. Your family, friends, colleagues, and the Alzheimer's Association are here to support you along the way. Together, we can get closer to our ultimate goal, the first survivor of Alzheimer's. The day with the most light is the day we fight. Start now. Select your activity at alz.org/thelongestday.
We are at 1 more minute for us to resume our presentations. Just a second.